Hello, this is Chapter 13 Assessment and Care of Patients with Fluid and Electrolyte Imbalances. The objectives is to differentiate among osmosis, diffusion, filtration, and active transport, define and describe third spacing, describe the nursing management of fluid volume deficit, and to describe the nursing management of fluid volume excess. First thing we're going to do is we're going to just review some basic terminology that you guys should be familiar with from studying when you were in biology. Um, Basically, here it's just showing that what all people um, are trying to achieve, and that is a phase of homeostasis. Um, you have various components um, that help a person arrive at that area of homeostasis, which is basically optimal physiologic function, and that mostly depends on a balance of body, water, and electrolytes. So, in a healthy person, the volume, concentration, and composition of body fluids are regulated by renal, metabolic, and neurologic functions. You have uh, body fluids are distributed between two main compartments. You have what they call the intracellular fluids and extracellular fluids, and together, the intracellular fluids and the extracellular fluids, the sum of the fluids constitute what they consider total body water. Um, there are the clinical significance of what the blood pressure is. The blood pressure is an example of basically what they call hydrostatic filtering forces, and it moves through the whole blood from the heart to the capillaries, and that's where filtration can occur so that you can have an exchange of water, nutrients, and waste products between the blood and the tissues. So you can see here on here where it's showing where you have the endothelial cells and the intracellular spaces, the pores through which diffusion, filtration, and osmosis can occur. The whole blood is moved from the large vessels and to the small, and that's how the filtration occurs within that system. Okay. I forgot to tell you, I wanted to discuss with you that basically, so that you can put it in some type of perspective, um, that there are three processes that are important, to control normal fluid and electrolyte balance, and they work together to maintain balance so the internal environment remains stable, even when the external environment may, go through a change. So, like, you have like the three processes, and these are filtration, diffusion, and osmosis. They determine how, when, and basically where fluids and particles move across the cell membranes. Filtration is basically the movement of fluid through a cell or body or blood vessel membrane because of what they call hydrostatic pressure. So they may be hydrostatic pressure differences on both sides of the membranes. And the filtration occurs because of differences in the water volume pressing against the wall spaces, which they're kind of confined. Water molecules in a confined space constantly presses outward against the confining walls. This pressure of water molecules is what they call hydrostatic pressure. It is a water pushing pressure because it is the force that pushes the water outward from a confined space through a membrane. So basically, like to give you an example of that occurring, it's the same thing, just like how they talk about, if you want to talk about maybe, let's talk about Hurricane Katrina, for instance, and the water, the pressure, and you know how they say that like the levees broke because after a while that pressure, it was confined, you know, the water was confined, and it's finding ways to try to seep out and go into, you know, go in, but it's just, but the pressure is so great that then sooner or later the water, it pushes with a and it breaks out of that confined space through a membrane. So it's going to find ways to leak, it's going to find ways to get through. And that is basically what we're talking about when we talk about hydrostatic pressure. Blood has hydrostatic pressure because of its weight, it's thicker than water and volume, and also because the heart is pumping blood into the arteries, creating basically more pressure. When nothing stops it, water filters through the membrane from the space with higher hydrostatic pressure to the space where there's lower hydrostatic pressure. And so, therefore, you know what you're trying to do as a result of that is maintain or obtain an equilibrium, which is reached when enough fluid leaves one space and it enters the other space to make the hydrostatic pressure in both spaces equal. Okay, so in essence, blood pressure is an exchange between blood and cells only, and they only take place at the capillaries. Veins serve as an expandable reservoir, and ventricles blood leaving the left ventricle enters the systemic arteries shown by the expandable elastic region. So this is an example of exchange between blood and cells, and they only take place at the capillaries. And then you'll see where the veins or like a reservoir, which enters into the left ventricle and the systemic artery shown by the expandable elastic region. And that's the area right up here. Okay. Edema is basically, it develops with changes in normal hydrostatic pressure and differences. If the capillaries, are, which are tiny blood vessels, leak fluid into the surrounding tissue, the area will start to swell, and this could be due to capillary damage or increased pressure. So basically, essentially, edema is considered a swelling and is caused by fluid retention, and excess fluid is trapped into the body's tissues. The clinical significance of this, basically, we can go into what they call a process called diffusion, and most of you guys probably have um, either tackle this or discuss this if you took a biology class in the past. And diffusion is important in the transport of most electrolytes and particles through the cell membranes. Um, Sodium pumps and also glucose cannot enter most cell membranes without the help of insulin. That may be something important for you to remember. So, through this process, if you think about diffusion, it's like considered like movement of particles. And so the free movement of the actual particle, it goes across the permeable membrane from an area of high concentration to an area of low concentration. And so the diffusion of these particles into and out from cells and fluid spaces occur via the energy from the vibration of single molecules Each collision increases the speed of particle movement and allows molecules to spread out evenly through the available space. They may move from an area of higher numbers of molecules to an area of lower numbers until an equal number is present in all areas. Diffusion of particles continues as long as a concentration gradient exists between the two sides of the membrane. When the concentration of particles is the same on both sides of the membranes, that's when you reach your period of equilibrium, and only an equal exchange of particles continues. So that's basically how that process works. For instance, a clinical significance of, for instance, even the process of what they call osmosis. The thirst mechanism is an example of how osmosis helps maintain homeostasis. The feeling of thirst is caused by the activation of cells in the brain that respond to changes in osmolarity in your blood. For so osmosis. Now, first of all, you got to remember we discussed diffusion, and I want you to equate diffusion with the movement of particles. So you're going to say from a high concentration to a lower concentration, and they're trying to reach equilibrium. Well, with osmosis is the movement of water only through a selectively permeable or semi-permeable membrane. For osmosis to occur, a membrane must separate two fluid spaces, and one space must have particles that cannot move through the membrane. Because the membrane is impermeable to these particles, they cannot cross the membrane, but water molecules can. The concentrations of particles in the fluid spaces on both sides of the membrane are equal even though the total number of particles and volumes of water are different. Equilibrium occurs by the movement of water molecules rather than the movement of particles, which like is in the process of diffusion. Okay, so fluid balance. The terminology fluid balance is fluid intake, which maintain fluid intake approximately equal to fluid loss to reduce the risk of reduction. I'm going to say that again. You want to maintain fluid intake approximately equal to how much you fluid lost to reduce the risk of dehydration. Fluid loss, which is the minimum amount of urine needed to excrete toxic waste products, is between 400 to 600 milliliters. Insensible water loss is about 500 to 1,000 milliliters per day. So you want to think about it like that. You want to think that, okay, uh, a minimum amount of urine needed to excrete toxic waste products is 400 to 600 milliliters per day. Normally, if you think about it, remember how we have always discussed a person putting out a minimum of 30 meals in an hour period of time. Um, well, if you think about it and do the math, 400 to 600 meals um, is probably right about what a person would need. And then as far as insensible water loss, like with through sweat and that type of thing like that, is anywhere between 500 to 1,000 milliliters a day. So make sure that you do remember about the main thing about as far as maintaining some type of fluid balance is related between the uh, you want what you take in to equal what you put out. If you, for instance, aren't putting out what you take in, you it will result in what? It will result in a person being fluid overloaded. If you are putting out more than what you're taking in, it'll result in a person being dehydrated. So if you want to look at it like that, that could be an important way to. Okay, what I did want to elaborate on also is I wanted to go into, like, there are impacts that um, age might have on fluid balance as well. So you may want to take note, and I have it based on, like, the uh like five different systems. Of these five different systems, you have the skin, the renal, the muscular, the neurologic, and the endocrine system. And based on age, now I'm just slowly stating on how age could possibly impact changes of fluid balance. Okay, for instance, uh, for the skin, um, age can make that change. It can relate as far as loss of elasticity, decreased turgor, and decreased oil production. And as a result of that, um, you tend to have a more unreliable indicator of what a person's fluid status is. So it's kind of harder for you to assess it because of the fact that the person has loss of elasticity and decreased turgor when they age. Um, as far as, and also I forgot to tell you that makes the skin more dry, and it can easily be more damaged skin. For older people, as far as the renal system, one would have more decreased glomerular filtration and decreased concentrating capacity. As a result, what that does is you tend to have a more poor excretion of water products and increased water loss. Um, Muscular, you have a decreased muscle mass when you age, which results in decreased total body water and greater risk of dehydration. Neurologically, um, they may have a diminished thirst reflex, and when a person has a diminished thirst reflex, they tend to have a decreased fluid intake, and they have an increased risk of dehydration. And lastly, as far as the endocrine gland, they tend to have adrenal atrophy. As far as the endocrine system, you have adrenal atrophy. You have poor regulation of sodium and potassium, predisposing the patient to hyponatremia and or hyper. So, common causes of fluid imbalances. For instance, let me give you some ideas. We're going to relate it as far as dehydration and fluid overload. Let's start with dehydration, which is considered a fluid imbalance. And I want you guys to pay um, close attention to the terminology that I use because I call dehydration is a fluid imbalance. Fluid overload is considered a fluid imbalance. Um, One example of dehydration is hemorrhage, vomiting, diarrhea, profuse salivation, fistulas, ileostomies, profuse diaphoresis, burns, severe wounds, long term of having an NPO status or nothing by mouth. A person could be on diuretic therapy, GI suctioning, hyperventilation. Like for instance, when a person is running, for instance, and they stop and they're tired and they hyperventilate. That's why you're trying to replace fluids because they're losing um, through sweating and various things like that. They're losing fluid. A person that's on diuretics, a person that's in renal failure, especially the early phase, uh, diabetes insipidus, difficulty swallowing, impaired thirst, unconsciousness, fever, impaired motor functioning. All these types of things can contribute to a person being dehydrated. Okay, for instance, the examples, I have a few examples. Um, as far as fluid overload is concerned, excess of fluid replacement, a person in renal failure, so the late phase. So, dehydration, I had told you, was renal failure as an example of things that can cause dehydration. But and I said early phase, but in fluid under fluid overload, the renal failure is in the late phase. So I want you to make that distinction. Okay, heart failure can cause fluid overload. Long term corticosteroid therapy can cause fluid overload. Um, a person who has SIADH, which is syndrome of inappropriate antidiuretic hormone, which we will discuss that when we start getting into endocrine, and psychiatric disorders with polydipsia, where a person drinks a lot of water or fluid, and then of course water intoxication. So those are some things that also can contribute to a person having a fluid imbalance, which could possibly be a fluid overload. Okay, then people would have sometimes what they call a hormonal regulation of fluid imbalance, and the hormones that's in your body. For instance, you have the main ones that we discussed in this class would be aldosterone, uh, ADH, which is the antidiuretic hormone, and then the NPs, which is natriuretic peptides. And as far as under aldosterone, aldosterone is basically a hormone that's secreted by the adrenal cortex whenever sodium levels in the extracellular fluid is decreased. It prevents both water and it prevents sodium loss as well. When aldosterone is secreted, it acts on the kidneys, on the nephrons of the kidneys, and it triggers the kidneys to like reabsorb sodium and water from the urine back into the blood. This action increases blood osmolarity and blood volume. Aldosterone prevents excessive kidney excretion of sodium. It also helps prevent blood potassium levels from becoming too high. The second one that I discussed was the antidiuretic hormone, or ADH. Sometimes you'll see it written like that. Or vasopressin is produced in the brain and it's stored in the posterior pituitary. And like I said, if you could just remember just some basic things about these, because we will go into them a lot more in detail when we discuss fluid and electrolyte imbalances. But when you have increased blood osmolarity, the ADH releases from the posterior pituitary gland, and the ADH acts directly on kidney tubules and collecting ducts, and it makes them more like permeable to water. And as a result, more water is reabsorbed by these tubules and returned to the blood. And it decreases the blood osmolarity by making it more like dilute. And the less water is then less water that's reabsorbed and more is lost from the body in the urine. And as a result, the amount of water in the ECF, or extracellular fluid, decreases, bringing osmolarity to normal. And then the last is the MPs, and they are secreted in response to increased blood volume and blood pressure, which stretch the heart tissue. And the MP binds to the receptor sites in the nephrons, and it creates effects that are opposite of that of the aldosterone. So then the kidney reabsorption of sodium is stopped or inhibited. At the same time, the glomerular filtration is increased, causing increased urine output. The outcome is decreased circulating blood volume and decreased blood osmolarity. So, and you got to make sure that you realize that any medication or situation that disrupts aldosterone secretion or release or leaves the patient at an increased risk for excessive water loss and resulting hyperkalemia. Okay, so we're going to talk about a little bit more that like earlier when we was talking about dehydration, and I just want to really because it's very important, especially with the population getting so much older. When we talk about assessing dehydration, and earlier I said the fluid intake is less than what is needed to meet the body's fluid needs, resulting in a fluid volume deficit. And older adults have less total body weight and are at greater risk for dehydration. Anyone who is cognitively impaired, which means that they can't really understand what's going on and either cannot obtain fluids independently, maybe they're immobile, or make their needs for fluids known, is at an even higher risk. So take all of that into consideration, um, that they're a very vulnerable population, older people, and they just have a lot of metabolic changes that occur when they age, and that impedes them being in homeostasis. And so a lot of times, a lot of the symptoms and different things like that with older people can often, be masked. But I do want you to take note of, like all the little different things that I said when you're assessing, for fluid balance. Okay, so when assessing, like especially or particularly for dehydration, you must remember that obtaining an accurate weight is the most sensitive and cost effective way to monitor fluid balance in the home. Okay, I'm going to say that one more time. When assessing for dehydration, you must remember that obtaining an accurate weight is the most sensitive and cost effective way to monitor fluid balance in the home. So you would take a history, and one way of like organizing history data to assess the patient's fluid status is to use Gordon's functional health patterns, which collects information on nutritional metabolic patterns. For instance, I what is your typical daily food intake? They'll ask them describe a day's meals, snacks, vitamins. How is your elimination? So basically, it's collecting the information on the things that I told you already was one of the most important things to know about when you're assessing whether or not you're assessing a person, whether or not their intake is equal or whatever towards as much as they're putting out. So when you're asking them those type of questions, those are the type of things that you want to know about. Um, so you need to weigh the patient directly. 1 liter of water weighs 1 kilogram. So body weight is a good indicator of excess fluid loss or retention. So if they have changes in daily weights, um, can help anybody determine whether or not a person is having some type of fluid imbalance. You're gonna You're going to include all, when you obtain your urine output, you're going to include everything, all kinds of losses. I don't want you to just focus in on like just the urine output or sweat or diarrhea, insensible loss. Like I was telling you, like for instance, if a person got a fever, you're supposed to take all of that type of thing into consideration when you're calculating their output. Older adults often, and sometimes you'll find them, they'll be using diuretics and laxatives, and that can disturb their fluid balance. And sometimes they'll knowingly do that type of thing and won't say anything. Sense of thirst or excessive drinking, exposure to hot environments, living at a high altitude, and the presence of kidney or endocrine diseases. Assess the patient's level of consciousness when you're taking their history, and physical assessment, and their mental status. Because sometimes when a person is dehydrated, they can be confused, or lethargic, because changes in mental status often occur when a person has some type of fluid imbalance. Ask the patient and changes in ring or shoe tightness. I can't wear that ring anymore. I can't do this. A sudden decrease in tightness may indicate uh, dehydration. So, if they, for instance, had a ring that was too tight, and then all of a sudden it wasn't anymore. It could just go, like opposite, the same as a person that's overloaded. Okay, there would often, a lot of times, be different. You want to do like a cardiovascular changes, or good indicators of whether or not a person is hydrated or not. Heart rate increases in an attempt to maintain blood pressure with less blood volume. So a person gets tachy. Peripheral pulses are tend to be weak and difficult to find when a person is dehydrated, and easily blocked with light pressure. So the blood pressure also decreases, as does the pulse pressure, with a greater decrease in systolic blood pressure. The changes in blood pressure may cause the sensations of lightheadedness and dizziness. This problem increases the risk for falling in older people, especially among older adults. Neck veins are normally distended when a patient is in the supine position, and hand veins are distended when lowering the level of the heart. Neck veins normally flatten when the patient moves to a sitting position, and with dehydration, neck and hand veins are flat even when the neck and hands are not raised above the level of the heart. So, the respiratory changes include an increased rate, because the decreased blood volume is perceived by the body as decreased oxygen or hypoxia. So, the increased respiratory rate, when a person breathes more, they're trying to attempt to maintain oxygen delivery. Skin changes occur that indicate dehydration. You're going to assess the skin and mucous membranes for color, moisture, and turgor. You're going to assess skin turgor by checking how easily the skin over the back of the hand and arm can be gently pinched between the thumb and the forefinger to form a tint. How soon the pinched skin resumes its normal position after you let go of the pinch. And this might not be a reliable indicator in older dogs, because of the fact that they do lose elastic tissue, and they have increased dryness, but you can do it in like maybe middle-aged adults. In generalized dehydration, is really kind of more skin turgor, poor. Um, when a person tense, it remains for minutes after pinching the skin. Um, And no skin depressions can occur with gentle pressure. The skin is usually dry and scaly. In dehydration, or mucous membranes are not moist. They may be covered with a thick, sticky paste-like coating, and a person may have cracks and fissures in their mouth, or and the surface of the tongue may have deep furrows in it. Also, when we discussed earlier, we talked about neurologic changes with dehydration, which may include alterations of mental status and body temperature status because blood flow in the brain is reduced. Mental status changes, especially confusion, are more common among older adults and may be the first indication of a fluid balance problem. The patient with dehydration often has a low grade fever, and fever can also cause dehydration. A patient with a temperature higher than 102 or 39 degrees Celsius, sometimes for longer than 6 hours, is especially at risk because the increased body temperature increases the rate at which fluids are lost. For every degree or increase in body temperature above normal, a minimal of an additional 500 milliliters of body fluid is lost. So that's pretty fantastic. I mean, if you really think about it, the older adult begins to lose more body water at lower levels of fever. As far as renal changes in dehydration, they affect urine volume and composition. So you want to monitor urine output, comparing the total output with the total fluid intake and daily weights. The urine may be concentrated with a specific gravity greater than 1.030. So listen, 1.030, that specific gravity lower than that would be an indicator that a person is dehydrated. The urine, like I said, is concentrated. It'll probably be strong, dark with a strong odor. The output will probably be below 500 milliliters a day. Um, so you need to weigh the person at the same time on the same scale, and when possible, have the patient wear the same amount and type of clothing. Um, any weight loss over a half pound per day is really almost considered excessive fluid loss. Um, when you're doing labs, when you're trying to assess whether or not a person is considered dehydrated, you always want to assess these particular lab values. So I would want you to note what the status. So with you guys knowing what the normal values are of these, if we were to give you a scenario, you would know whether or not it would be indicative of someone being dehydrated. If they have an elevated hemoglobin, if they have an elevated hematocrit, elevated serum osmolarity, elevated glucose, elevated protein, elevated BUN, and most even their electrolytes, the basic electrolytes may tend to be elevated, and then they will have hemo concentration, and that is the reason why, because everything is so much more concentrated, that the rates and the levels are higher. Okay, so as far as nursing interventions, first and foremost, it's just basically patient safety, and then fluid replacement, and then any type of drug therapy that they'll tailor based on that particular patient and what they feel that patient needs at that particular time based on their lab results. And just make sure that if you are um, possibly replacing fluids or something like that. Make sure that you don't replace them too fast, because if you replace fluids too fast, that makes a person prone to cerebral edema. Okay, now we can talk about fluid overload. Um, fluid overload is excess of body fluid, and most problems caused by overhydration, which we basically talked about that already, and most and they're related to fluid volume excess in the vascular space, or to dilution of specific electrolytes and blood components. So, the dehydration, you think of more concentration, more concentrated, but for fluid overload, you think of less concentrated. So, therefore, a lot of the labs and stuff would probably be a lot lower than when a person is dehydrated. If you just think about it in terms of concentration. Okay, so just like you would do um, when you assess for a person that's dehydrated, you assess for the same types of things. You will assess for cardiovascular changes, you will assess for respiratory changes, neuromuscular changes, gastrointestinal, and skin and mucous membranes. Um, Patients that generally have fluid overload often have pitting edema. They have other manifestations which are seen in cardiovascular, uh, uh, respiratory, GI, neuromuscular, and skin, like I had said earlier. Um, these changes that occur, if you want to take note, would be, for instance, you're making an assessment. A person would have cardiovascular changes. They would have an increased pulse rate, a bounding pulse quality, full peripheral pulses, elevated blood pressure, decreased pulse pressure, elevated central venous pressure, distended neck and hand veins, engorged varicose veins, and weight gains. If you look at the difference when I talk about cardiovascular earlier for dehydration, it's the exact opposite. Okay, for the respiratory changes, you will have increased respiratory rate, shallow respirations, increased dyspnea or shortness of breath with exertion or in the supine position. You would have ooh, excuse me, increased dyspnea or shortness of breath, moist crackles present on auscultation. And think about that crackles, you guys. You're hearing a person is overhydrated at this point. They have fluid overload. So that makes sense. You can even relate it to the things that you learned when we was talking about respiratory. The neuromuscular changes would include altered level of consciousness, headache, visual disturbances, skeletal muscle weakness, and um, paresthesias. And if you don't know what paresthesia is, look it up. But usually, basically, what people feel like numbness or something. But look it up a little bit more in detail so you won't forget it. GI changes would be increased motility, enlarged liver, as far as skin and mucous membrane, you're gonna have cool to touch, paleness, and then they're gonna have pitting edema, and especially in dependent areas like their feet, and sometimes you see it in people's hands and stuff like that. So you're going to concentrate on patient safety, which includes preventing fluid overload from becoming worse, um, which could lead to them having pulmonary edema and or heart failure. Um, the older adult would be really at great risk for cardiac, kidney, and liver problems. Monitor for indicators of increased fluid overload by the signs that I told you earlier, like the pulse bonding, increased neck vein distension, crackles, reduced urine output, increased peripheral edema. You're going to do that every 2 hours because you don't want them to have no pulmonary edema because that can quickly lead them to death, basically. The patient with fluid overload and dependent edema, a lot of times they're at a risk for skin breakdown. So use a pressure reducing or pressure relieving overlay on the mattress. Assess the skin pressure areas daily for signs of redness or open areas, especially the coccyx area, elbows, hips, and heels. And because many patients who have fluid overload, they may be receiving oxygen by mask or nasal cannula, and you need to check their skin. Um, Usually, um, around their mask and around their nose, around their ears, and that kind of area. And then you want to change their position. They may be, as far as drug therapy, they may prescribe them diuretics. Um, and that's only if, for instance, a person doesn't have renal failure as a cause for them having overload. I'm going to say that again. They can prescribe diuretics for the patient, but it's only if they don't have renal failure uh, uh, being the result of them having that fluid overload. Um, so you're gonna always be looking at like ECG, EKG patterns, cardiac changes. You're gonna be assessing specifically sodium and potassium levels every shift or so. As far as their nutrition, you want them to have restricted sodium from 2 grams to 4 grams daily, which is really what they consider no added salt, to foods. And because you don't want them to be absorbing more fluid, because wherever the salt more or less goes, the fluid goes. It follows, and we already went through this process when I was telling you about diffusion and about going to a level of higher concentration and lower concentration. Um, you're going to monitor intake and output. You're going to check the specific gravity. Uh, Below 1.005, it may indicate fluid overload, because basically what they're saying is that the specific gravity is lower, it's dilute. um, Fluid retention may not be visible, um, but if they have what they call rapid weight gain, that can be the best indicator of fluid retention and overload. So each pound of weight gain equates to 500 milliliters, and that's after the first half pound. So you want to look at that, and I repeated that earlier, so I just kind of really want, when I keep saying the same things over and over again, I would like for you guys to really listen. Okay, now I'm back. What I wanted to discuss, and I want you to give give yourself a chance to possibly take note of this. Okay, everybody. I'm back. What I wanted to talk about was on page 177, table 13.4. You have characteristics of common intravenous therapy solutions. Specifically, I want you to know whether or not a particular solution is isotonic, hypertonic, and hypotonic. And at the bottom of that, it has the different solutions. Like, of course, everybody knows that normal saline is isotonic. So I urge you to memorize that chart. We'll talk about the next set of electrolytes. What we'll do is we'll just go on all the way down. We'll start with like sodium and talk about the normal changes. I mean normal ranges and what type of things that you need to look for when you have like hyper and hyponatremia. Okay. As I was talking before, the first electrolyte, we should be able to go through these very, very, very quickly, is sodium. I am expecting you guys to know the normal ranges of um, sodium, and as we go on, and what the proper expression of it is, and like when you say hyponatremia, that's low sodium, like that type of thing. So the normal range of sodium is 135 to 145. Um, Sodium is generally vital for skeletal muscle contraction, cardiac contraction, and nerve impulse transmission, and obtain a normal osmolarity and volume of the extracellular fluid. Okay, so the first one that we're going to talk about is hypo no tremia, which means that is a low sodium level, which means that it's below 136. A person that has hyponatremia will experience cerebral changes. Um, um, a lot of times they may have a episode of like acute confusion. They'll have neuromuscular uh, changes where, for instance, their deep tendon reflexes may diminish and they may have muscle weakness. Um, and you could test these areas by like testing a person's hand grips, etc. Also, a safety alert is if the muscle weakness is present. Always make sure that you always immediately check respiratory effectiveness because ventilation a lot of times depends on adequate strength of respiratory muscles. So if you having any type of neuromuscular changes, you may want to check that. They will often suffer from intestinal changes. They'll have what they call increased motility, which causes nausea, diarrhea, and abdominal cramping. Um, and then they will have cardiovascular changes when they have hyponatremia. They tend to have a rapid, weak, thready pulse. The peripheral pulses may be difficult to palpate, and it's easily blocked with light pressure. Um, and if you think about this, these are some of the same symptoms that we talked about that occurs when you have hyponatremia. You, as a result, would probably have more fluid overload. You have a hypervolemia, which is more fluid overload, and you'll have cardiac changes and that type of thing. Um, with normal or high blood pressure, peripheral pulses are full and difficult to block, and however, they may not be palpable if edema, if they tend to have some type of edema. Um, for hyponatremia, the nursing intervention and care of the patient with hypo um, um, natremia is monitor the patient's response to therapy and prevent hypernatremia and fluid overload. So you can use all processed foods. They are considered high in sodium, prepackaged foods, cheeses, that type of thing. You can do drug therapy, nutrition therapy. Drug therapy will probably reduce, for instance, you want to reduce a person having like a loop or a thiazide diuretic. Um, you might want to administer a hypertonic saline solution. Um, um, or something like that. You might want to administer like a lithium for nutritional therapy. Like I told you before, you really do want to have increased the oral sodium intake. So foods like that. And so then the next electrolyte is hypernatremia, which is serum sodium level over 145. Okay, so if that's over 145, you have nervous system changes, skeletal muscle changes, and you would have cardio vascular changes. When you nervous system, of course, once again, you're gonna have a decreased attention span, inability to recall like recent events, and um, you're gonna have skeletal muscle changes. You're gonna have muscle twitching, irregular muscle contractions, and as a result, that can result in a person having decreased contractility because high sodium levels slow the movement of calcium into the heart cells. So you're going to measure blood pressure and the rate and quality of the apical and peripheral pulse levels. Interventions would include nutrition therapies, um, um, and drug therapies. Mainly the therapies would be the hypotonic solutions. Um, and you would want to administer somebody something like a Bumex or a Lasix or some type of diuretic in that case. Nutrition therapy. Um, you would want to prevent sodium and beverages and that type of thing. So you're doing just the opposite. In the next case, you have the next lab or electrolyte, I'm sorry, would be potassium. Potassium's normal range is 3.5 to 5.0 milliequivalents per liter. Depolarization and generation of action potentials, as well as regulating protein synthesis and glucose use and storage, is what the purpose of potassium is. Okay, so those are the functions of potassium: depolarization and generation of action potentials, as well as regulating protein synthesis and glucose use and storage. The first thing we're going to talk about is hypokalemia and hypokalemia, which is low potassium, is a serum potassium level below 3.5 milliequivalents per liter. It can be what they call life threatening, because everybody's system is affected. Um, you would have respiratory changes. Um, your respiratory changes are likely because of the weakness of the muscles needed for breathing. You'll have musculoskeletal changes. So you would have like hyporeflexia because your hand grasps and your deep tendon reflex would be lower. Your cardiovascular changes would be you having a weak or thready pulse rate. Neurological symptoms that a person would be, believe it or not, they would be have short-term irritability, anxiety, and then that would later be followed by lethargy. You would have intestinal changes, and because of the smooth muscle contraction and intestines tracts are decreased, and we even talked about that when we related it to the cardiovascular. um, you would have abdominal distension, and they would have problems probably more with constipation and that type of thing. Um, hyperkalemia would then be a put I'm sorry, would be a potassium level that would be greater um, than the 5, because remember we talked about the 3.5 to 5. So we, you know, the normal range. I'm sorry. Let me go back. I'm sorry. Serum potassium greater than 5. So you'll have cardiovascular changes are the most severe problems from hyperkalemia and are the most common cause of death in patients with hyperkalemia. So what they're saying is that when a person has an increased potassium level where the level is greater than 5, you really need to take a look at the cardiovascular problems, because when a person has hyperkalemia, they may have bradycardia, hypotension. They'll have all kind of EKG changes. They'll have like ectopic beats and just all type of. So they'll have like all types of like arrhythmias and that type of things, to put it short. Um, that would probably be one of the main concerns. You want to look at neuromuscular changes when a person has an increased potassium. Sometimes they have paresthesias. Remember that terminology again. And what occurs with that is they'll have a tingling and burning sensations and numbness in their hands and feet. Sometimes that'll happen to somebody and they'll tell you. It could be somebody that's on a diuretic and they're taking potassium supplements, and I mean there are times when you can actually eat too much or take too much of that. So they'll have those type of problems. Um, and then they'll have, of course, the neuromuscular changes that we talked about, the paresthesia and the different problems neurologically. And then intestinal changes with hyperkalemia. They'll have slow GI motility, and they tend to have constipation. Um, so for a person with hyperkalemia, sorry, the preferred treatment for hyperkalemia is probably what you mostly will see is a person using Kxalate, which binds excess potassium in the colon and it carries it out of the body. Also, you would do the cardiac monitoring and treat um, and treat it as needed, so that you can just have some type of early recognition that there are dysrhythmias or other manifestations going on. And then health teaching. Um, and even sometimes they will every now and then give people some calcium gluconate 10% through like a central venous catheter, because calcium a lot of times binds to potassium as well. Um, so but what it would do is it what it does is it the what really happens with the calcium is that it decreases, like you know how I was saying that people be having arrhythmias and stuff like that. The potassium tends to decrease, like what do you call it, like myocardial excitability, protecting people against the arrhythmias that I told you about. So that could be them giving the 10% calcium gluconate, but you can't give that intravenously because it does cause somewhat some burning and that type of thing. Okay, the next electrolyte would be calcium. The normal range, 9 to 10.5 milligrams per deciliter. And calcium serves as a mineral with functions closely related to those of phosphorus and magnesium. And if you think about it, people always talk about calcium and phosphorus and magnesium together. What calcium, how it works is it absorbs dietary calcium, requires the active form of vitamin D, and then calcium is stored in the bones. And calcium also works with the parathyroid hormone and the thyroid calcitonin. So it has basically those distinct functions as far as calcium is concerned. The first thing that we're going to talk about, you guys, is we're going to talk about um, hypocalcemia, which is low calcium, which means that if you got the range of 9 to 10.6 for calcium, then anything below a 9 milligram per deciliter, excuse me, 9 milligrams per deciliter would be a low calcium level. Also, whenever we talk about calcium, there are like things that you need to know culturally, and these things do come up like as far as when you take exams and that type of thing as well. Lactose intolerance um, um, is real common among Asians, blacks, and American Indians. And it generally does not occur in Caucasians. Um, People with lactose intolerance, they cannot use the nutrients in milk and have cramping, diarrhea, and abdominal pain after they ingest dairy products. Also, knowing this, you got to know that dairy products are, or what is responsible for like a lot of their calcium and vitamin D. But people with lactose intolerance may uh, have difficulty like obtaining enough calcium and vitamin D from other sources. So you got to go to things like the rich leafy green veggies and that type of thing to uh, make sure that you have enough. Also, as far as women is concerned, um, postmenopausal women are at risk for chronic calcium loss. So once a woman is menopausal, they're at risk for chronic calcium loss. Um, and it's related to reduced weight bearing activities and decrease in estrogen levels. And so you just need to know that a lot of times what happen is through hormone therapy and that type of thing. They or supplements, they try to increase this in this women, and but if you're not careful, these type of women tend to be more prone to like osteoporosis and that type of thing. And oh, and what I wanted to tell you was the some of the causes of a decreased calcium level would be like maybe somebody having Crohn's disease, which is like a malabsorption syndrome. If a person has kidney disease, kidney failure, diarrhea, that type of thing, a lot of times you'll see them having decreased calcium. Uh, Also, signs that I can tell you about and considerations, especially when you talk about neuro muscular changes. People have when they have low calcium level, as you can see on the pictures here. Um, they will have palmar flexion, which would indicate a positive Trousseau sign, and you can see that on figure 1314 in your book on page 189, along with them having the twitch, uh, which is Chopstick sign, which is a sign of hypocalcemia, and that's a figure 1315. Both of these that you see right here are in your book as well as a result. Um, so there's intestinal changes, cardiovascular, and skeletal changes. Um, as far as cardiovascular changes, it involves the heart rate, and it may be slower or either weak and thready or a little bit slightly different. Also, intestinally, they're going to have increased peristaltic activity, so they're going to have hyperactive bowel sounds. And then, as far as skeletal changes, if they have chronic, they will, of course, be more prone to osteoporosis, and they won't have as much bone density, which really, if you think about it, uh, they're more prone to fractures. Interventions, of course, you guys, is drug therapy, which means that you're going to give people aluminum hydroxide, which is like a TUM or some type of oral or even IV replacement, depending on how severe. Nutrition therapy, we already talked about calcium rich foods. Um, Environmental, basically because of the fact that people have over excitable membranes. They say that they want you to lower your voice or keep them adjust the lighting and that type of thing, because they would tend to be prone to like seizure activity. So you would protect and take care of these people like you would people who are people prone to seizures. Hypercalcemia is the total serum calcium level above to 10.5 range. Um, because the normal range of the serial calcium is narrow, even small increases have can possibly have severe effects. Um, Effects of hypercalcemia occurs first, primarily in what they call the excitable tissues. um, which is like the cardiac tissues, and all of the basic systems and stuff are affected. You'll have cardiac changes such as increased heart rate and blood pressure, pulse rate. You'll have poor tissue flow such as cyanosis and pallor. Um, um, you'll have a more tendency to have blood clots, um, neuromuscular tendons. You'll have decreased deep tendon reflexes without paresthesia. Um, intestinal. You'll have a decreased peristalsis and constipation and anorexia, and then bowel sounds are often hypoactive or absent, so it can affect all the overall systems. Um, Drug therapy would be IV sodium chloride, which is isotonic, furosemide, calcium, phosphorus, and calcitonin and biphosphonates, and prostaglandin and synthesis inhibitors. So those are the type of drugs that you do, and most of them, what they'll do is uh, those type of drugs tend to interfere with calcium absorption. And then, of course, they do have dialysis, and then, of course, you're going to do cardiac monitoring. The next electrolyte is phosphorus, and phosphorus is the body is most known for bone growth and development. The normal range is 3 to 4.5 milligrams per deciliter. Phosphorus is needed for activating vitamins and enzymes, forming a adenosine triphosphate and assisting in cell growth and metabolism. Some of the foods that's high in phosphorus is meats, fish, dairy products, and nuts. Plasma levels of calcium and phosphorus exist in a balanced reciprocal relationship. Remember how I talked to you earlier and I had discussed how kind of like phosphorus and calcium kind of works hand in hand. So I just really want you to keep that in mind. The first thing that I'm going to discuss is the hypophosphatemia, which is the serum phosphorus levels are below 3.0 milliequivalents per liter. Most of the effects of hypophosphatemia are related to decreased energy metabolism and imbalances of other electrolytes and body fluids. Um, Hypophosphatemia has several manifestations. Primarily, you have cardiac, musculoskeletal, and hematologic systems, and the central nervous system. Um, uh, 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 I'm sorry. Manifestations. Um, the cardiac is that the peripheral pulses a lot of times are low. Um, Let me see what else. Everything is weak. Musculoskeletal is skeletal generalized weakness. Hypophosphatemia, you have decreased bone density, of course, because as it relates to calcium loss as well. And then central nervous system, people tend to go as far as like the seizures and have irritability, and it's kind of like the same thing and same type of changes as in with calcium. Oh, I forgot to tell you guys also know about the musculoskeletal changes, the rhabdomyolysis. Rhabdomyolysis. Look that up, and basically what it means is like muscle deterioration or loss or breakdown. Okay. Hypophosphatemia interventions. Of course, you're going to orally replace phosphorus. You're going to give vitamin D supplements. You can give IV phosphorus. You can also eat foods that have increased phosphorus rich and calcium uh, uh, fish foods. You're gonna get stuff like fish, beef, chicken, pork, organ meats, nuts, and whole grain stuff. That's the kind of stuff that you want to have. Also, you need to tell them don't go for just the. They should really um, probably try to avoid the foods that are high in calcium if you really want to just uh, concentrate on phosphorus. So you're going to have foods that are high in phosphorus. You want to try to avoid milk, cheese, yogurt, greens, and that kind of stuff, and rhubarbs and that type of things. You want to go for the fish, beef, chicken, pork, all kinds of organ meats, nuts, and whole grains. Okay. Um, the next is hyperphosphatemia, which is a 4.5 milliequivalent. Um, Whatever problems you have from high phosphorus levels is mirrored to a person having decreased calcium. Uh, it really, truthfully, though, don't cause as many direct problems with the body function, but causes include renal insufficiency, certain cancer treatments, increased phosphorus intake, and hypoparathyroidism. And we'll talk about those things when we discuss your endocrine and disorders and that kind of thing like that. So, because calcium and phosphorus ions exist in the blood in a balanced reciprocal relationship, management of hyperphosphatemia entails the management of hypo. So, it's the same as when you have hypocalcemia. Okay, the next one is uh, magnesium. Magnesium 1.3 to 2.1 milligrams per deciliter. Magnesium is critical for skeletal muscle contraction, carbohydrate metabolism, ATP formation, vitamin activation, and cell growth. Hypomagnesium are caused by increased membrane excitability and the accompanying serum calcium and potassium balances. Um, they really don't go a lot over that. What type of things um, happens? You would have a positive Trousseau sign and Chauvistek sign. Um, um, it's kind of basically central nervous system depression, confusion, um, muscle smooth, like you're gonna have increased motility in your GI, um, those type of symptoms. So basically, what they usually do is loop diuretics. Um, Let me see, and that's mainly the only ones that I can think of as far as the treatment. Okay. And hypermagnesemia, it's the same thing, and it's just the opposite of hypo. Hypercardiac changes would include, of course, the bradycardia. You got a 2.1 milliequivalent per liter or above. lab result. Central nervous system. Of course, the person's gonna be depressed. Neuromuscular changes. You're gonna have a decreased nerve impulse, so you're gonna have a reduced deep tendon reflex. And respiratory changes will probably include, if you got decreased muscular, skeletal, and that type of thing, will be depressed. Uh, so basically, you're gonna have magnesium-free IV fluids. You're gonna give some type of loop diuretic like furosemide, and you're going to give calcium. And then the last but not the least is chloride, which is 98 to 106 milliequivalent per liter. Imbalances of chloride usually occur as a result of other electrolyte imbalances, usually corrected by interventions for correcting other electrolyte or acid base problems. So that really relates to other um, lab imbalances, and when we start getting to like bicarb and those type of electrolytes. But those electrolytes that we just mentioned, just right then and there, um, those are like the main ones. When you have people and we introduce you to like, for instance, if you want a person to have a CMP, like a complete metabolic or a basic metabolic, basic metabolic panel. Those are the basic labs and stuff that you will see when you draw that type of lab work. Next, chapter 14, assessment and care of patients with acid base imbalances. You're going to your objectives are describe the relationship between free hydrogen ion and level and pH, explain the role of bicarbonate in the blood, compare the roles of the respiratory system and the renal system in maintaining fluid and electrolyte acid base balance, identify patients at risk for acid base imbalances. um, Use laboratory data and clinical manifestations to determine the presence of acid base balance imbalances, correctly interpret arterial blood gases to determine whether acidosis is respiratory or metabolic in region, uh, in origin, and coordinate nursing care for the patient with the acid base imbalance. Okay, so what we're going to go over, we're going to first start. And today I know the best way to understand, so I will seem like I'm lightly touching on this, but like when we play games and stuff with you guys and we have y'all answer questions, a lot of times this is the best way to understand what's going on with acid base imbalances. It's really, really difficult to explain if a person don't have like working knowledge. So let's start with like what a normal pH is. Normal pH is arterial blood is 7.35 to 7.45. Normal pH for venous blood is 7.31 to 7.41. First of all, you just got to know that that's 7.35 to 7.45 is generally what we're looking at as far as normal pH. So if you had a pH of 7.3, which is low, the person tending will be more of in an acidotic state. If you have a pH of a 7.48, a person would be more in a alkalitic state. Okay, so that's the first thing that you have to understand. Okay, so for a person to have a change in normal pH level, when a person has a change in normal pH level, it can definitely interfere with many of the bodily functions. And the reason why it can do that is it can interfere with the hormones. It can interfere with like the fluids, how they're being exchanged in the body. It can change what excitable membranes. It can decrease the effectiveness of many hormones and drugs. If a person is in an acidotic state, it could change, how their body is using certain drugs and different things like that. Um, so we want to talk about acid-base chemistry, and I will go over this briefly. You got acid, you got bases, you got buffers, and then you have body fluid chemistry, which consists of bicarbonate ions and the relationship between CO2 and hydrogen ions. Um, so, acids release hydrogen ion into solution, and bases release bicarb. So first of all, you have to relate hydrogen to acid and bases to bicarb. If we were to mix, for instance, an acid and base together, the hydrogen ion would combine with the bicarb ion. And if you was to and so then therefore you would create uh water, the H2O, and that's what molecule that you uh would make. A lower pH means a higher H. A higher pH means a lower H. So if you have a lower pH, that means that you got more hydrogen ion, which is an acid. If you have a higher pH, that means that you have a lower amount of hydrogen ion. So that's how it's related. A lot of times, if you can't get past that point, it's very, very difficult for you to understand bicarbs and hydrogen ions. Think about it. So, how you relate in pH to hydrogen ions is that the more hydrogen ion that you have, the more hydrogen ion um, that a person have, they have a lower pH. The less hydrogen ion that a person has, they have a higher pH. Because if you think about it like this, as it relates to even a bicarbonate ion, if a person is in alkalic state, that means their pH is higher. And if anybody wants to come and discuss that and talk about it more and try to get some understanding, I'm sure that we are be able to do that for you. Okay. If you have an ionic compound and you put it in water, it will break apart into two ions. If one of those ions is hydrogen, for instance, the solution is acidic. If one of those ions is bicarb, the solution is basic. The pH scale is actually like, for instance, a measure of the number of hydrogen ions in a solution. If there are a lot of hydrogen ions, the pH is very low. If there are a lot of bicarb ions, that means the number of hydrogen ions has to be low. So the pH is high, or it's alkalic or basic. So you really, I can keep saying that over and over again. Here we have some um, what we call demonstration of the understanding. Now, I have ran in the past into a lot of students that did not understand this. So, if you don't understand it, you really need to move quick and come to us to get additional help, because you will be getting a quiz in the upcoming week, if I'm not mistaken. Okay. So, this is like, basically a breakdown. So when we think also, you guys, in terms of more of a metabolic state, if I was you, I would think more of a bicarbonate and hydrogen ions. I would like I would like put that into that realm and pH. Okay. When we go to respiratory, acid base and control mechanisms, you have when chemical buffers act I'm sorry, buffers alone cannot prevent changes in blood pH. The respiratory system is the second line of defense against changes. Okay, basically, all that they're saying about that, when we're talking about respiratory um, and acid bases and that type of thing like that, um, oh, when we talk about that, we're talking about it like, for instance, in terms of hyperventilation means that you got an increased rate and depth of breathing. So what they're saying basically is that when a person hyperventilates, they're trying to blow off more of, carbon dioxide. That's what they're trying to blow off. When a person, and so as a result, that person is probably in an acidotic state at that point. When a person is in an acidotic state, they have a lot of carbon dioxide, so they're trying to blow off as much as possible carbon dioxide because they want to increase, that. With hypoventilation, as a result, you have less CO2 and it's lost through the lungs, and more, as a result, you have less CO2 when you this lost through the lungs. So therefore, a person is probably more in an alkalotic state. Um, and they're trying to. That's a response to them having low levels in their blood. So basically, right here, um, uh, I just want you to look at this, and it's telling you you got a decreased PaCO2, which means you have a decreased hydrogen ion. So therefore, as a result, you're going to have inhibition or of central chemoreceptors. You're going to have a decreased rate and depth of respiration. See, you got a you the reason why you're doing that is because you want to have uh put yourself more into a place where if you hyperventilate, you'll have more PaCO2 and you'll have increased hydrogen. And then as a result, you'll stimulate your central chemo receptors, and then you'll increase the rate and depth of the respirations. You'll start hyperventilate and blowing off. So it's just like it's going in a big circle. Okay. When you have renal acid base control mechanisms, the kidneys are the third line of defense against wide changes in body fluid and pH. The stronger for regulating acid base balance, but take longer than chemical and respiratory mechanisms to completely respond. So although like we can regulate our balance through kidney function, it takes it this usually the kidneys, they kick in when something's been going on for quite a while. They're not as fast as reacting, like where you hyperventilated. As far as respiratory, respiratory is usually one of the first faster lines of defense. Renal kind of goes along with metabolic, and that usually happens almost in when you hear people talk about like compensation and that type of thing. That's when usually the kidneys start kicking in when something has gone on for quite a period of time. So um, I think one slide, oh yeah, yeah. Like for instance, one slide here, it talks about compensation, and it says the body attempts to correct changes in the blood pH. If you have a pH below 6.9 or higher than 7.8, a lot of times it can be fatal because it has an effect on so many parts of our body systems. Your respiratory system is more sensitive to acid base changes. So, it can begin compensation efforts within seconds to minutes, where the renal compensatory mechanisms are much more powerful and result in rapid changes in extracellular fluid composition, and it's not triggered unless imbalance continues for several hours to days. And so that's what I was talking about when I was explaining how, people a lot of times have respiratory compensation being faster than the kidneys compensatory mechanisms. The respiratory compensation, um, for example, the lungs compensate for acid base imbalances of a metabolic origin. Okay, so respiratory. Now think about it. You got a metabolic origin, something that's happened metabolically, and then in order for you to have respiratory compensation. Example: you got prolonged running, and it causes buildup of lactic acid. So a person's been running for a long time, and they have a buildup of lactic acid. Um, Therefore, them having a buildup of lactic acid, you have the hydrogen ion levels in the extracellular fluid is increased. So, if you have more ions, that means that the pH is low. Remember, I was telling you about the hydrogen being related to acid? Well, breathing is triggered in response to the increase. So the carbon dioxide levels to bring the pH level can go back to normal. So therefore, a person would probably start hyperventilating. The renal compensation, for instance, example, you have a healthy kidney can correct or compensate for changes in blood pH. Um, when the respiratory system either is overwhelmed or is not healthy. For example, a person has COPD and retains carbon dioxide, which means they're in an acidotic state. They're in respiratory acidosis in the blood. The blood pH level falls, becomes more acidic, like I said, and then the kidneys, as a result, excretes more hydrogen ions to try to so get rid of it. A COPD is chronic, it's not acute. Remember, we said that the kidneys would kick in and do the compensatory mechanism when something has been going on for a long time. So, the kidney excretes more hydrogen ions and increases the reabsorption of bicarbonate back into the blood. Acid base imbalances, metabolic acidosis, respiratory acidosis, combined metabolic and respiratory acidosis, and you have metabolic alkalosis and respiratory alkalosis. Okay, metabolic acidosis. You have to be aware and be able to, based on the words and the numbers and stuff, what these means. If you have metabolic acidosis, you have a lot of hydrogen ions, which means there's under elimination of hydrogen ions. You have a lot of underproduction of bicarbonate ions, which means there's over elimination, under elimination of bicarbonate ions. So therefore, you got metabolic acidosis. So you need to be able to look at uh, this process and be able to pick it out. So that's how a person is in metabolic acidosis. So they have decreased, and there will be some questions where they'll be like, "This mean they have increased hydrogen ions in the blood, and they have like that." So you got to know that the hydrogen is hot and it's acidic. So if you got a lot of hydrogen or a low pH, because remember it's split up, then if you got a lot, you're in a acidotic state. Respiratory acidosis. Okay, so as far as respiratory acidosis, when you have respiratory acidosis, when you're in that state, you're retaining carbon dioxide. As a result, you have respiratory depression. As a result of respiratory depression, inadequate chest expansion, and airway obstruction, and reduced alveolar capillary diffusion. So basically, what we're saying is we're not getting enough oxygen. So when a person has respiratory depression, when they're not expanding their lungs out, when they have airway obstruction, um, that's when a person can be put into a state of respiratory acidosis. Um, Combined metabolic and respiratory acidosis comes from basically a uncorrected respiratory acidosis always leads to poor oxygenation and lactic acidosis. So you build up that. Combined acidosis is more severe than metabolic or respiratory acidosis alone. So of course you don't want to have metabolic and respiratory acidosis. That's all it's saying. And they can lead to cardiac arrest. Is an example of a problem that can happen when a person has combined metabolic and respiratory acidosis. So, upon obtaining these things, you need to get their history. You want to ask the person whether or not what their history is, what's going on with them. You want to uh, uh, see whether or not um, they're having I'm sorry, central nervous system changes of any sort. I mean, are they confused? Are they irritable? Um, you're going to use your Gordon's functional health patterns as we did earlier. You're going to see what types of things is really going on with this person. Are they irritable? Are they lethargic? Are they um, reduced the tendon reflexes, or they having Kussmaul breathing. You're going to question them about all these type of things. Skin changes. Um, Usually when a person has acidosis, um, they're warm warm and dry, and usually pink, flush tone, because you have a lot of vasodilation dilation going on. Also, okay, laboratory assessment. In order to do a laboratory assessment, um, when you have metabolic acidosis, the pH is usually less than 7.35. The bicarbonate is less than 21. The PO2 is normal, and the PaCO2 is normal or slightly decreased. Serum potassium is high. This is how your labs will look. You can see a pH is lower than 7.35. What did I tell you guys earlier? Um, they're in a acidotic state. If you have a bicarb of less than 21, bicarb is alkalotic, right? So therefore, if you have less bicarb, you're in a what? Acidotic state. Remember I told you guys to look at the bicarb in terms of metabolic. So pH low, bicarb low, acidotic. PaO2 and all that is normal. The PaCO2 could be slightly decreased because carbon dioxide is, oh, okay. So that is like what metabolic acidosis looks like. Okay, now respiratory acidosis. The pH is low. Remember we said on when the pH, which could go with either or, metabolic or acidosis. Low means acidotic, high means alkalotic. So the pH is low, the PaO2, which means the oxygen level is low, and the CO2 is high. If you got more carbon, that means you're in an acidotic state. Serum bicarbonate, it may vary because that's for primarily the metabolic. Serum potassium levels elevated if acidosis is acute. Serum potassium levels are normal or low if renal compensation is present. So these are the things that's going on with your body. You got interventions for metabolic acidosis. You want to hydrate because if you add fluid, what it'll do is it'll dilute it and it'll put you more in the acidotic state. Um, if a person is a diabetic, you want to give them insulin so that you could treat diabetic ketoacidosis. You want to give them anti-diarrheal drugs because they're dehydrating themselves and they're putting themselves in a more acidotic state. You also only want to give them bicarbonate only if serum bicarbonate levels are low. Okay, think about these treatments, you guys. Interventions for respiratory acidosis: maintain a patent airway and enhance gas exchange. You're going to do drug therapy, oxygen therapy, pulmonary hygiene, and ventilation support to prevent complications. So mainly, what you want to do is you want to give them oxygen therapy because the carbon dioxide, the more that you have in the blood, is going to put you into an acidotic state. If you have more oxygen in the blood, it's going to put you more in an alkalotic state. For So going into metabolic alkalosis, um, when you have metabolic alkalosis, you have a increase in the base. So you have an increase in bicarbonate. Um, when you have what they call an acid deficit, which means you don't have enough deficit. Uh, this can occur when a person has prolonged vomiting. A person can have excess in the cortisol, hyperaldosteronism, thiazide diuretics they may be taking, and prolonged NG suctioning. When you have respiratory alkalosis, that can come as a result of hyperventilation. Because remember now how we talk about people having small breathing, and I want you to think about them trying to correct themselves. If a person has uh, in order for a person, when a person has hyperventilation, a lot of times they're trying to blow off the excess CO2 that they got in their blood. So as a result, they're trying to put themselves in a more they put themselves in a more alkalotic state, and that's what they're saying that happens as a result of you doing that. So if you're blowing off CO2, you're putting yourself in more of an alkalotic state. Anxiety, fear, improper vent setting, um, and that type of thing like that. Um, Collaborative care. You want to assess the individual. You want to look at the central nervous system changes, like the Trousseau signs. Remember back when we was talking about with the flexion and the Chebystek sign. We discussed those signs when we was talking about hypocalcemia earlier, cardiovascular changes, and various respiratory changes. Interventions to prevent further loss of hydrogen. You want to do potassium and calcium and chloride ions, and then you want to restore the fluid balance, and you want to monitor changes. Okay, so that'll be including some of the lecture. What I hope to gain from this, you guys, because it's very difficult to put fluid and electrolytes on tape, is that hopefully you guys, what will occur is that maybe if you just listen to it over and over again, you might remember some things. But the things that you don't, we're going to also try our best to give you some type of maybe an extra little study session for the quiz on next week. Thanks so much. Bye, guys. That'll be it.